Good day. I'm Matthew Weir, a professor of medicine at the University of Maryland School of Medicine in Baltimore. Welcome to this program titled Preventing Death in Type 2 Diabetes and Chronic Kidney Disease Patients. What is the primary target of treatment? Joining me today is my good friend George Bakris, a nephrologist and professor of medicine at the University of Chicago Medicine in Chicago, Illinois, and Ken Mahaffey, a cardiologist and professor at Stanford University School of Medicine in Stanford, California. Welcome, gentlemen.
Welcome.
Hello.
So why are we discussing this? We're going to really try to focus on the very powerful link between cardiovascular disease and type 2 diabetes, particularly as it occurs in patients with chronic kidney disease. Remember, it is chronic kidney disease patients who die from cardiovascular disease, not the other way around. And obviously, our main goal in people with diabetes and chronic kidney disease is to prevent cardiovascular events. Remarkably, if you look at the Medicare population in the U.S. who have diabetes and chronic kidney disease, they are 5 times as likely to die as they are to reach dialysis. So this is a very important statistic which needs to focus our attention on dealing with the cardiovascular disease risk in people with diabetes and chronic kidney disease. Now we're going to focus our conversations today on some of the newer observations, actually serendipitous observations initially, with the SGLT2 inhibitors, bringing together both nephrologists and cardiologists to discuss these topics and what's new and what it means for our patients with type 2 diabetes today. So Ken, why don't we turn our attention over to you and have you focus on some of the important observations from these, what were really designed as cardiovascular outcome safety trials to address the issues of whether SGLT2 inhibitors were actually safe to give to patients. Yet it was the other way around when we finished the studies.
You're exactly right, Matt, right? It's phenomenal, hasn't it? Since 2008, when the FDA published that guidance document about the development of diabetic drugs, we've now had over 145,000 patients randomized in clinical trials, 45,000 alone in trials of SGLT2 inhibitors. We've had basically 3 large dedicated cardiovascular outcome trials. We've had 1 dedicated renal trial, and we've had 1 dedicated heart failure trial. So the 3 cardiovascular outcome trials, EMPA-REG, DECLARE, and CANVAS, showed similar findings. EMPA-REG and CANVAS showed that canagliflozin and empagliflozin SGLT2 inhibitors were superior to placebo for reducing cardiovascular death, MI, and stroke. DECLARE showed that dapagliflozin was non-inferior. But very importantly, all these trials showed that there was dramatic reductions in heart failure, hospitalization, and cardiovascular death, something we didn't anticipate.
And was not even part of the MACE endpoint as these trials were designed for safety.
Not at all. And when we designed these trials, we didn't even collect ejection fraction at baseline. That's how much of a serendipitous observation this has been. And now what obviously has happened is we've got a dedicated renal trial in Credence that George is going to talk a bit more about. And then we have DAPA-HF, dedicated trial with dapagliflozin in people with reduced ejection fraction that showed remarkable reductions in heart failure hospitalization and cardiovascular death. So really a consistent message of reducing death, MI, and stroke, as well as heart failure hospitalizations.
Fantastic. And, you know, it's even carrying on further now because now there's an effort to really explore the benefits even in people without diabetes, which I think is really a remarkable consideration when you think about this class was designed to treat people with diabetes.
Exactly. Really striking, and we need to learn more about these drugs, about why we're seeing these benefits, because we're not sure yet.
Yeah, exactly. Well, we'll come back to that in a few minutes because what I'd like Dr. Bakris to discuss is some of the kidney aspects because, again, we have some very similar serendipitous observations initially, which have now been confirmed with actually 1 new prospective randomized control trial in people with chronic kidney disease.
Right. Well, as Ken said, in looking at the cardiovascular outcome trials, there were pre-specified renal endpoints that were looked at in EMPA-REG, CANVAS, and DECLARE. And these trials, from a renal perspective, were considered, I think most nephrologists would say, gee, these are for really healthy patients. We don't see people with GFRs of 70 and 80. Nevertheless, when they looked at renal outcomes, all of them showed a significant benefit in slowing progression of kidney disease across the board. It didn't matter what your baseline risk was, cardiovascular risk was, you got a renal benefit across the board. And then, on the basis of that, the interesting thing is credence was started before any of these trials reported. And in fact, credence had started and we were recruiting almost 2 years before EMPA-REG reported, and that was the first trial that came out. So we already were hypothesizing that there was a renal benefit of these trials. We didn't really understand the mechanism, and bad news is we still don't understand the mechanism. But the bottom line was this was ongoing.
Well, let me ask you this and ask Ken. I mean, do you think that this is a potential explanation for the heart failure benefits? I mean, I can understand the blood pressure story maybe a little bit, but, there have been many theories that have been promulgated concerning just how these drugs might be so helpful. I mean, Ken, what are your thoughts in that regard?
We still don't really have a clue about how these drugs actually work to reduce heart failure events. But the good news is there's a lot of work going on. We have an incredible repository of biosamples from both Canvas and Credence, as well as do other investigators, to try and explore these things. I do think there's probably a little early effect on heart failure because of some diuresis. But I think that the long-term benefits that we see as these curves continue to separate for reductions of heart failure hospitalization over time. And there may be changes in myocardial energetics and other phenomenon that can be explained.
Substrate utilization.
Yep.
I mean, there are all these theories out there.
Matthew, let me remind you, that was true in those trials with healthy kidneys. If we look at credence, and especially forget about the people at stage 3A. If we look at people at stage 3B and 4, there was 0 hemoglobin A1C reduction in people with stage 4. And yet, the kidney protection was still seen. Oh, and by the way, there was 5 millimeter reduction in blood pressure.
Well, my point exactly.
Yes.
Don't blow off the blood pressure as being important.
Not blowing it off.
And the same thing as you commented on the continued improvement in renal outcomes in the lower EGFR tertiles and quartiles. We saw the same thing with cardiovascular outcomes. They're at higher risk, they have higher event rates, but they still had absolute and relative reductions that were striking.
Well, I think the important issue is, yes, we have serendipity on our side in this case. No doubt about it. And obviously, often medications are developed for scientific purposes based on physiological observations and targeting specific pathways that could be, concerning in that regard. In this case, it's the other way around. We've suddenly discovered these drugs are wonderful, capable, but we have no idea why. And so I really, to me, the excitement is to figure out how they really work. We've got to learn. But I think the proof of the pudding is going to be adopting the use of these therapies in our patients at risk. And one of the struggles I have as a clinician is to explain maybe to a cardiologist that a diabetes drug is good for their heart disease or heart failure. Or, how do you explain that a diabetes drug is good for, a nephrologist to treat a patient with a GFR of 35 who's spilling a gram of protein in their urine? That's going to be, a leap of faith in order to provide the perspective in this regard.
Matthew, let me ask you a question. A diabetes drug. So if we give a sulfonylurea, that's a diabetes drug. You're going to lower glucose, irrelevant what the kidney function is. If you give a DPP-4, you're going to lower glucose, doesn't matter what the GFR is. This drug doesn't lower glucose when the GFR is low because it's dependent on that. So can you really call it a diabetes drug?
Well, the problem is these drugs have been used in tens of thousands of patients for several years now.
Yeah.
And the perception is they're a diabetes drug.
Bingo. The perception is, and as Ken told us, in non-diabetics, they had a heck of an effect on heart failure reduction. So you want to rethink that a little bit?
Well, the other issue that comes up, obviously, too, is usability in clinical practice. Because every healthcare provider is going to challenge the therapeutic index of a new drug. And that is, the benefit to risk ratio. And let's be fair, ACEs, ARBs, mineralocorticoid receptor antagonists, critical therapies in people with heart failure, also in people with kidney disease, although I think the MRA are lagging behind in data, but I think that data is going to come soon too. But we have limited problems with expanding the use of what I call evidence-based or guideline-based therapy because of changes in creatinine, changes in serum potassium. Might the SGLT2 inhibitors be potentially a more user-friendly approach because of the lack of robust effect on changing GFR or serum potassium in clinical practice?
Well, I think the short answer is yes. And how would you respond if I were to tell you that early next year there are certain major guidelines that would say, you know, metformin, I don't know, how about SGLT2 as first line? If you want to pick metformin, you can pick it, but SGLT2 has got a lot of evidence, level 1A evidence. You're the insurance company. You're not going to pay for level 1A evidence when guidelines are saying this? I think you better rethink that, doctor.
You know, part of the issue here that we're getting at is that when we think about drugs in certain disease states or certain provider therapeutic areas, we get very siloed. We get siloed in terms of how we conduct trials, we get siloed in terms of how we interpret trials, and then we get siloed in terms of how we implement the data from the trials. And I think this is a great example of where we need to bring the cardiologist, the nephrologist, the endocrinologist, all integrated around our primary care colleagues to figure out a team approach to using these therapies so that it's not just, you have type 2 diabetes, you have diabetic kidney disease, you're at risk for heart failure, go back to your endocrinologist to get a prescription for an SGLT2 inhibitor. No, the cardiologists need to be comfortable taking ownership of that. The nephrologists need to be doing the same thing, the endocrinologist, and we got to have support from the primary care. I think it's critically important moving forward if we're going to see the outcomes that we see in the trials reduced in clinical practice.
Let me just say, okay, it may be more kindler and gentler for the heart failure or the CKD patient. But we also have some other issues to deal with. You know, many of these drugs, as they were introduced to the marketplace, there were reports of ketoacidosis, fractures, amputations, genitourinary tract infections, Fournier's gangrene, all these, you know, small but yet important side effects can occur. But how do we interpret these effects with the totality of the potential benefit? And again, this is where we get into therapeutic index. I mean, Ken, in the heart failure patient, are these going to be important issues for you?
Oh, I think so. I mean, when we start, physicians are going to have to understand that those are potential side effects. The most common ones, as you know, are the genital infections. And good thing is those can generally be managed. They're not comfortable for the patient, but most of the time, the patients stay on the drug and manage the infection. So good news there, they're going to get continued benefit. The diabetic ketoacidosis, very uncommon event. You know, 4,400 patient credence trial, we had 11 total events of diabetic ketoacidosis. More with canagliflozin than placebo, but still very, very low.
11 out of 4,400.
Very low.
Yeah.
The amputation story is a little bit more complex. Clearly, in the Canvas program, there was an excess in amputations, predominantly minor amputations of toes, but some also of more major amputations. We didn't see that signal in credence. Not at all.
Despite what might be considered as an even higher risk population with vascular calcification, chronic kidney disease.
And with more amputations coming into the trial than Canvas ever had.
Yes. And so we're still not sure exactly what a mechanism might be from the credence experience, but we do know that in the type 2 diabetic population with diabetic kidney disease, like credence, the way we studied those patients and implemented the protocol, there was no excess in amputations.
You know, as I interpret the original reports about the ketoacidosis concerns, it was primarily in people who are on insulin pumps where the needle got dislodged, and they basically had no insulin exposure. And again, one of the concerns with these drugs is it could increase the risk of ketoacidosis under those types of circumstances.
Well, it goes beyond that, because basically the people that developed ketoacidosis were people that got sick. And they got sick, and guess what? They stopped taking their insulin because they weren't eating. Oh, I'm sorry, they kept taking the SGLT2. And so I think the easy way for clinicians to think about this is very simple. And this is what I do in practice. If you look at the genital infections, everybody says, oh, those are really common. In Japan, they were almost non-existent. It's all about hygiene. It's all about keeping the area dry. I'm a big fan, and I tell all my patients this, I've yet to see a problem with it. Basically, keep the area dry, use some cornstarch or some baby powder that's cornstarch based to keep that absorption there. That's huge. If you're worried about ketoacidosis, if you get sick, stop both insulin and SGLT2. I think those are key lessons to understand.
Well, might also the risk of genitourinary tract infections be minimalized in people who have no glycosuria, such as people with markedly reduced GFRs.
Thank you very much.
Where there is no glycosuria at all
Exactly.
to speak of.
Yep.
All right, well, going back to the Credence study, Ken, I'm quite interested with regard to the heart failure story there. We all know remarkably how kidney disease progression and incident heart failure hospitalization seem to be linked in lockstep. You know, what were the observations from Credence with regard to heart failure in these people with the compromised GFRs?
Yeah, so I think there's three important observations from Credence along those lines. One is we saw marked reductions in heart failure hospitalizations in the study in general. That was the key cardiovascular outcome. We saw no attenuation of that benefit as we looked at patients with lower and lower eGFRs. And then finally, for the first time in any of these SGLT2 inhibitor trials, the heart failure benefit was seen in patients that were both primary prevention groups, that is no history of atherosclerotic disease, and in people who had a prior history of atherosclerotic disease secondary prevention. First time, all the other previous CVOT trials had showed basically neutral effect for death, MI, and stroke, and very little effect for heart failure reduction. We're going to see more data coming out at the American Heart Association and subsequent meetings later this year looking at heart failure benefits in people with history of heart failure, not just history of cardiovascular disease, but history of heart failure or not. So stay tuned.
And I think it's important to emphasize that the people in these studies were well treated, better treated than I would submit to you in real world circumstances. Right. Because in order to get in Credence, you had to be on a RAS inhibitor.
Yep.
That was not an option.
Over 99%.
And again, in DAPA-HF, again, extremely high percentage of people were on guideline-based recommended therapy. Beta blockers, RAS inhibitor, MRA, and yet you have an incremental advantage here.
Not just incremental. 40% relative risk reductions in a high event rate endpoint.
Yeah.
We haven't seen anything like this in so long.
Right.
Well, and George, for us in nephrology, it's been 20 years since we've had, you know, the advent of the ARB clinical trials to really show a difference. And this showed what? A 30% relative risk reduction benefit for end-stage renal failure on top of ACE inhibition.
Right.
Or ARBs being used.
Right.
So really, for the first time, there is some excitement,
Yep.
I would say, in both our heart failure circles and our kidney disease circles, that we can do more for our people who have type 2 diabetes, heart disease, and kidney disease. And remarkably, with drugs that were designed for diabetes, yet don't really change the glucose that much in these people with reduced kidney function.
I think we can honestly say that the spousal couple, that is the heart and the kidney, have found a happy home now with the SGLT2s.
And I would say the other thing that I'm most interested in these clinical studies, and I'd love to hear some thoughts from cardiology and nephrology in this regard. You know, when a new therapy comes out, 100% of people don't get better with it. I mean, maybe it's different for penicillin for group A, beta hemolytic streptococcal pharyngitis. Okay, fine. But I also think we need to do more to examine responder, non-responder phenomenon with the SGLT2 inhibitors in people with heart failure and with kidney disease. I mean, are you aware of any efforts now to look at these issues in these newer studies, to take a look at that? Are there some potential explanations which could help us ferret out who's going to best respond to these therapies?
Well, I think it's really incumbent that we do. And I mentioned before, we have great biorepositories of biosamples that I think is going to help us at least look at patients who may be more likely to have a treatment effect that will include information that's beyond the typical clinical phenotyping that we do, right? We look at older people, we look at people with prior history of certain diseases that are going to increase their event rates and likely going to increase their treatment effects. So I think the biomarkers are going to be key. The other thing, when people think about that concept of precision medicine, precision health, what we also have to think through as health systems is how we're going to also provide pathways for busy clinicians and patients who have to be involved in shared decision making. We need implementation strategies that are also going to be helpful to promote the use of these proven therapies.
You know, George, you once described SGLT2 inhibitors to me as a very interesting therapeutic class. Could you tell me again, remind me what you told me that time?
That these are, based on the totality of the evidence, these are cardiorenal risk-reducing drugs that have glycemic control or glucose lowering as a beneficial side effect. And if you actually look at the spectrum of them, once you get to GFRs below 45, you can forget about glycemic control. The evidence is abundant there. And yet, cardiorenal benefit forges ahead. These drugs are not just hemodynamically active. They also have anti-inflammatory properties, which have already been described, but just in the last 18 months. So, as Ken said earlier, we've scratched the surface. We're trying to get in deeper to figure out what's going on.
Well, in that sense then, Ken, what do we need to do to get the cardiovascular specialists, particularly those who deal with heart failure, how do we get them involved to understand more about this?
Yeah, I think we need to deliver a very concise message, and I'll keep it simple for cardiologists like me. I think we have one drug here that does three things. It helps with correction of the metabolic derangements that happen with diabetes. That's kind of the endocrinology domain. We've got marked reductions in renal outcomes, the nephrology domain. And then we've got great reductions in both ischemic endpoints, death, cardiovascular death, MI, and stroke, but also heart failure. And we need to think about using these drugs for all three of those benefits and not passing the buck when we see these patients in our clinics.
George, what about the nephrologist? What are we going to do?
I think the nephrologists need to understand this is not your mother's diuretic or some glucose-lowering agent. These are drugs. I think Ken said it brilliantly. We need to think about the nephrologists need to worry about the heart, not just the kidney, and they need to focus on drugs that are going to be good for both.
You know, for our audience today, I think there are a number of very, very important key takeaways. As with any new therapy, you need to evaluate the therapeutic index in each and every one of your patients. I think there are huge opportunities moving forward. There are many new trials still underway for both heart failure and kidney disease progression, so there'll be abundant new information moving forward. And, the experience and the totality of it now is really quite substantial. So this is not, the serendipity we discussed earlier. These are outcome trials that are being a priori planned to ask specific questions and see specific endpoints. So in finishing, what I'd like to do is ask Ken for you and then from George just a final couple of points for our audience.
Yeah, I think I'll go back to two concepts. One is the team science and also the simple pearls of multiple organs that can be affected by these drugs. And I'm thinking about now not diabetic CKD for chronic kidney disease, but CKD for cardiology, C, K, kidney nephrology, D, diabetes endocrinology. Let's all work together, use these drugs based on the totality of the evidence we see, and do good things for our patients.
George?
You know, as you know, it's rare that I can just concede to say that, you know, this is the best thing, but I think Ken summarized it brilliantly. I really cannot extend it any further. I think that is the mantra that we need to focus on.
Well, gentlemen, I'd like to thank you both very much for sharing your clinical experience and your knowledge with us. Obviously, you're both well experienced with these drugs, having participated in several of the clinical trials and obviously continuing